Now, just let me introduce you to the Centre for Muslim Wellbeing. I am a co-founder of this. It was a very long journey into how I got into this particular area of my industry. I am a registered psychologist. I've been working in this industry, predominantly working within Muslim and multicultural communities for the last 28, 29 years, pretty much my entire career. Started off working as a school counsellor in Islamic schools and realised very quickly how big the need was around offering firstly mental health literacy and offering lots and lots of different services, from psychological services, but also some really proactive programs, from anything from parenting and youth services, and so became very quickly being one of very few Muslim psychologists in the community some odd near 30 years ago. The Centre for Muslim Wellbeing is an organisation very close to my heart, aiming and working across the last 2 decades to get something like this founded. We are officially founded in 2017 when we got a lovely seeding grant from the Victorian government, but it has been a project in the works for many decades, actually, with many minds and many communities full of heart and knowing the need for this, but it's a community-based organisation for community. However, as much as what the Centre for Muslim Wellbeing was set up for, which is to basically offer mental health awareness training to multiple parts of our community members and to run other education-focused programs, it has also been to be informing the sector in an area that has really been waning for many decades. And you yourselves will be very lucky if you've attended a day, a couple of days, a workshop here and there across the course of your career, or perhaps if you're more recently trained through formal institutions or tertiary education, you may well have started to have some cultural responsiveness or cultural safety-like topics embedded in some of your subjects. But quite frankly, having also lectured in this space before at the Australian Catholic University, at times it can be not enough, not detailed enough, telling you what needs to be done, but not necessarily how. And that at times can leave clinicians with great intention to support their clients, regardless of the background that they come from, to the extent that they benefit from the treatment and stay engaged in that treatment. But sometimes we fall short. And unfortunately, as we'll go through today, there's lots of mental health disparities between mainstream majority communities and our multicultural communities. And so it's still telling us from those disparities that we're not doing a good enough job when it comes to what we're offering our clients or consumers. So culture matters. Passionate about culture. It informs lots of things about who we are. We often underestimate the massive impact that culture has in our lives. But what it doesn't inform is it tells us whether we're safe. It informs us, it gives us a sense of identity that we can articulate. It can inform ways that we think that we need to be good in some way or enacting goodness. It gives us a sense, or maybe not, about where do I belong, or it informs belonging or the lack thereof. What happens when we don't have enough cultural knowledge of the people that we work with? Well, what happens is we just tend to basically use our own frame of reference. And of course, that's informed by our own life experience and indeed our own cultural or racial background. So if we don't have enough cultural knowledge, we interpret each other's thoughts and beliefs and behaviours through the very narrow prism that is our own culture. So I often say culture is like, as in our own culture is like wearing glasses and we forget it's there. And it informs whether it's sunny outside or whether we can see something more clearly, but we forget that it's there. And so that we forget that when we're dealing with people who are in a degree of unwellness, how do we use culture in the room? How do we see it? How do we assess it? How do we allow it to inform our treatment formulations or indeed our relationship in the way that we're communicating with people? Now, if we minimize culture, you might have heard people say, well, I'm colorblind, like as in it's a color blindness where you just don't see it. And some people think that that's a good thing. But what happens is you miss so much about who a person is. And we'll go a little bit more into what ends up happening in the counselling room if we don't harness or ask questions about culture with our clients. The other thing that happens is that we can tend to see people's problems through the prism or different behaviours and beliefs only through the prism of personality and not necessarily cultural background. So that can lead us astray in our hypothesising about what's going on for this client. The other thing that can occur is and we have to be careful with this when we start to work with culture. And cultural intelligence is about finding this fine line of seeing it and harnessing it, but not exaggerating it or generalizing what you think you know about someone else's culture and overly relying on things like stereotypes or problematizing people's mental health issues through the prism of culture only, which can be incredibly alienating. So culture matters, and it informs all these things and so much more. I think I could have filled about 4 slides worth of what culture actually informs, but these are the things that I think are really related to working effectively in intercultural spaces or within diversity. Our values and beliefs, that's obvious. Communication styles, approaches to parenting and partnering, gender roles or our expectations for gender roles, family structures, attitude towards hierarchy, or more specifically power, sense of independence versus interdependence, which we'll go into a little bit more today, a sense of individual power, even the sense of self and or the need for autonomy, approaches to conflict resolution, problem solving, locus of control. Does someone internalize what's going on for them or externalize what's going on for them? A sense of time or time orientation, and the way people set boundaries, and so many more things. And I want you to think to yourself, if we don't know anything about who we're working with, all the assumptions that we make could be really jumbled up because, again, it's through the prism of our own eyes and our lived experiences. And we don't want to just project that onto the person in front of us. That then informs our hypothesizing about what's right or wrong, normal, abnormal, healthy, unhealthy, wellness, illness, etc. I like to say, just with those images in the bottom of this slide in particular, that culture is with us and dictates the way that we wake up in the morning, right through the day, until we go to sleep at night. Culture, believe it or not, informs how you write an email. Okay, I want you to think about this. How do you write an email? Did you think before I just said that it was culturally influenced? But it is. Okay. If you're like me, I like to get straight to the task, straight to the point. I barely put in the person's name straight away and then think, dear David, how are you going today? Have you got this task done for me? And I'm straight onto the task. It's very what we call task focused. Okay. And there's not that much chit chat because it's a professional email. Okay. And so it's very short and very direct. However, if I want to be a little bit more relational, I might say, hi, David, how was your weekend? How's the family going? How's Jill? How's the kids? How's your golden retriever? What are you up to? How's work? And so I might want to embed that with a little bit and slow down and become a bit more relational. Okay. And so our style, our culture influences how direct we are in our language or how indirect and how relational we are, just as an example. And so I want you to think about that even in terms of when you're working with people. Sometimes it might be an unconscious thing that you shift, but what cultural intelligence is, it starts to be, things need to be a deliberate choice based on the little things that you start hypothesizing about someone else's background, or things that you're picking up about the way they're communicating to you, things that you may not miss. They might ask you lots of questions about your personal background, and indeed, if you're very direct, you might feel, oh, okay, oh, we're talking about family, are we? Okay, let's go there before we get to the task. Okay, and it's a slight little difference of discomfort. Or indeed, if someone gets straight to the task, you might go, do they not care about who I am as a person? Because they haven't asked how I am. They haven't softened the language because they've just got straight onto the task. So it's a really interesting way that cultures are different and similar. Culture is quite literally in the brain. I love this. Culture isn't just something that's out there. Culture is in here. Culture is literally wired into our neural networks. Not only is the very obvious in areas of the brain, like language is a cultural capacity of the brain, tradition and cultural scripts are stored in long-term memory. That's why they're one of the last things that we keep doing. But this is one that I really love, and being much more recent research, albeit 2006. But Zhang found that when individuals from individualist cultures think about themselves and a close other, such as a parent or a mother, that 2 regions of the brain are activating, representing the self and other. Okay, that's fascinating. So I want you to think about it. Do think you were raised in an individualist family, not just being raised in an individualist country like Australia being one of the highest individualist countries in the world. But by contrast, when individuals from collectivist cultures think about themselves and an other, like a mother, only one region of the brain activates. And then I want you to think about the significance of something like that, okay, in terms of suggestions that someone needs to move away from the family because the family are dysfunctional. Okay, or someone needs to stand up for themselves in a particular situation against a family member, like a mother. If or excessive feelings of guilt or feelings of sadness by being away from someone or away from a place or location for perhaps individuals where there's one region of lighting up and there's no separation in the brain's experience. It's an amazing, it's a really interesting fact, which I think has lots of implications for how we work with people and the type of suggestions that we give them, thinking that they should just be able to separate themselves from other people. Okay. And then, or for individualist families, what does it mean to be separate from someone? Does that indeed infer that there's a greater tolerance, or does it infer that indeed someone might be feeling lonely more often because there's a separateness that's occurring in the brain? Keep going. I could hypothesize about this all day. The process of enculturation, which is culture starts in the womb, the quality of your maternal, your maternal environment is very culturally influenced in terms of the access of your mother to adequate food, healthcare, etc. The family system that she's being supported by as she's pregnant. The process of enculturation comes as soon as you basically get into the arms of your parents and you're being encultured. Either you're being rocked like this, or you're swaddled like this, or held over your shoulder, or put in a cot. It's all enculturation. Okay. We don't see things as they are, we see things as we are. We can delude ourselves by thinking that we're very open-minded and that our attributes, our personal attributes, makes us adequate for us to work with people who are culturally different to ourselves, and we are culturally different to other people as well. But we project whether we like it or not, which is why there's been a flourishing of workshops on things like unconscious bias, but in my opinion, it doesn't go further enough. A little bit about me. I think it's important to know who you're working with. My upbringing is very sixth generation Anglo-Celtic Australian, very stock standard upbringing, spent half my childhood in caravan parks on holidays, black belt in Taekwondo. I have one sister, I'm the eldest. Had a mum and a dad. My mum and dad were both teachers in different things, non-traditional teachers, and probably why I'm doing this today. Inherited some of their teaching. Mum was a teacher at the local dog school in obedience training, so very non-traditional, and then went on to teaching older women how to patchwork quilts. And Dad was a non-traditional teacher too, teaching older men how to restore vintage cars, a different type of teaching, but nonetheless sharing what they know. But for me, growing up, I was very culture blind. And I had a question posed to me the other day by someone to say, when was there a shift, in realising that I was indeed a cultural being? I grew up in Springvale South in Melbourne. It's a very multicultural area, and all of my friends are different backgrounds to me. And so diversity was something that I grew up with. So it was very normal for me. But I still had a lot of culture blindness. And at the time, that's how we existed. So we didn't necessarily grow up thinking about what it meant to acknowledge or how to go about having conversations with people about their cultural background. And quite frankly, as teenagers, it maybe wasn't our priority at the time. We just wanted to get along and talk about what pop group we were into or what we were doing on the weekend. But unfortunately, there's not many opportunities to progress conversations about culture. And so people are very awkward about it, as probably was I. And one of the fundamental shifts in my life was when I was about 18, 19, I actually decided to change faiths. So I was Catholic background nominally. And in my first year of psychology, when I went to the Australian Catholic University, actually, and we were made to study Catholicism, it gave me a great opportunity to connect with my faith, my original faith community, which was the Catholic community in Catholicism, but also I had friends and was starting to learn about a different faith called Islam. After about a year, I decided to become Muslim, and since that time, from about 19, have heavily embedded myself within Muslim communities. So it's going back about 30 years ago, revealing my age, and have since that time been heavily embedded in the Melbourne multicultural communities and some spaces overseas as well. And for a large portion of that time, except for the last couple of years, I was also in hijab. And that's a really interesting, that was probably my biggest shift, because coming from a majority white background and having the experience of essentially privilege for a very long time, it was a very different experience to essentially step into visible minority status wearing hijab. And very quickly started to experience what lots of other of our community members experience in terms of racism and discrimination, and people saying nasty things and massive stereotypes held over you, and a whole lot of different expectations, which really made me see the world in a very different way. Lots to talk about that. And if you come to the 2-day training, we'll talk about that a little bit more. But that also got me interested in areas such as racism and discrimination and prejudice against Muslim women and Islamophobia, and probably thrust me into a career like this, which 20 years ago, diversity training or cultural awareness training looked very different. And I think that this is what sets cultural intelligence apart, because I've been looking for a model for a very long time that I think would actually start to be able to do the job in bridging the gap, particularly in regards to mental health disparities. Many years ago, and to some extent this still happens, that when there's a new migrant community, there's a host of cultural awareness training. And cultural awareness training is an audience attends some training and says, come and learn about us, that group over there who's different from you. And in that 1 or 2 hours, or maybe day training, you'll learn around what, for example, Muslims believe, what their customs are, what their celebration days are, fundamental family structures maybe. But what I found is that, unfortunately, training like that, the sole focus on the others, okay? And it doesn't position that cultural awareness. It gives you a degree of cultural knowledge. And I think that is important, but it's certainly not the only thing to improve essentially an intercultural relationship between the group who's different to you, and you, who are also a cultural being. And this is very much related to a relationship between majority white community, where there is a privilege that comes with invisibility. If you leave your house and don't have to identify yourself, or have never been asked, where are you from? What is your background? What do you believe? Is your community going to condemn the action of one of your members? What do you think in regards to the behavior of one of your members? That all of a sudden you're othered. And if you've never had that experience, you believe that you have neutrality, that you are culturally neutral, and there is no such thing. It's just that if like in Australia, if we live in places where you've never had to define yourself, and going overseas doesn't always give that to people, okay? If 20,000 Australians are in Bali at any one time, that's not going to give it to you, okay? Because it's not diverse enough, it's not immersive enough to actually have to think about, who are you as a cultural being? What do you believe? How is that different? And it goes much deeper than a John Howard or Tony Abbott's, these are Australian cultural values. It goes much more than that. And I think we all cringe when we think about that anyway. Okay. I want you to think about you as potentially a clinician or someone in policy, and thinking around developing the idea that all clinicians need to have some cultural awareness, no matter where we're from, actually, no matter the type of status our group holds, majority or minority, that we can all start to lift an awareness about the type of relationship we want to create with people. But if you just hold it at this, it won't be enough. And it's proven to not have been enough up until this point. If you think, I try to connect with people based on who they are. Good, how do you do that? That's good in theory, but how? What questions do you ask? How does even that question inform what treatments you choose? Or I just try to focus on people's personality and their presenting problem, and not their background, as if their background, cultural background, doesn't have anything to do with It's separate to, it's not separate to, it's completely related to a presenting problem. And indeed, maybe some personality characteristics. So you don't want to completely dissect cultural background from what's happening for the person. But that's what happens because people feel awkward about it or not confident enough. Or comments like this, I see the person or their race or culture. If you've ever thought that, you're thinking that because you're a nice person, but it doesn't go far enough to acknowledge someone's deep lived experience that is very much influenced by things like race or culture. We work within diversity. We don't work with it. See the difference? We work within it, not with it over there. This is how policy has shaped our work with multicultural community members, with them over there, not us. We're somehow separate and different. That needs to shift. We work within it. Okay? We're all diverse. Imagine how many policies will need to shift for us to really conceptualize that in all its depth. You, the helper, are a multi-layered cultural being, even if you're a member of the majority or holding, if you have a white Anglo-Celtic background. You are a cultural being. And it's time for us to really start to unpack, what does that mean for us? And how does that influence the way that we work with people? Indeed, how does it influence the way that we write policy for the people that we work with or deliver services? I want you to think about this. I get a lot of clients, many from Muslim backgrounds, that come into my clinic where I am now. And they will very often articulate that they've come to see me because I'm Muslim and that I'll understand where they're coming from, or I'll understand who they are without them having to explain too much about the cultural scripts or cultural beliefs that make them who they are. But I want you to think about who you are culturally and racially to the clients or communities that you are trying to work with. Who are you first? How are you seen? How do they position you? Because that, if you can unpack that, and if you don't know, that's worthy research right there. Start to hypothesize. How am I seen? It's a weird thing. Look in the mirror or have colleagues sit opposite you and go, all right, here's what I see. Here's what I see. Just from the outside, here's what I see. Okay. But culturally, racially, and of course, people might get that really wrong. Okay. You could be, be white-skinned, you could have blonde hair, and you could be straight from Bosnia or Macedonia, and be an incredibly multicultural person, and have and culture is a massive part of your life, and identify as Australian, and a whole lot of different things. And I'm sure that there's so many other examples where how are you seen? Because people will position you first, but that's a really important start to improving the relationship that you have with people. If we minimize culture, we miss lots of opportunities. Okay. If we don't have enough information, and quite frankly, I'm really still surprised that so many organizations don't ask detailed questions in their intake forms about culture. So it might just have country of birth, if you're lucky, languages spoken, most likely. Okay. If you need an interpreter, you know the forms I'm talking about. But what about religion? So you can have questions on there, and it's over to people whether they answer it or not. But so many services still don't record lots of different things about culture as a starting point. So when I have clients come in, I can quickly start maybe hypothesizing what I know, and maybe I don't know anything about someone who I'm working with who has a particular cultural background. Great, that's the onus then is on me to do a bit of research on that, so that I can start to get a more deeper sense about who someone is and the type of social, psychological, familial, political context that person might be coming from, that then might be informing the presenting problem. If we don't ask about culture, we miss things that are really important about intergenerational trauma, migration history, cultural scripts about mental illness, families' response to being unwell, particularly when it's in relation to mental unwellness, the level of stigma that the person might be experiencing by not only having a mental health issue, but also in seeing the mental health professional. So very commonly in Arabic, psychiatrists are translated as crazy doctor. So why would you want to go and see one of them? Okay, if that's a very common translation. So again, mental health literacy is improving in all communities, and we've seen that because of who is coming into services like mine and surely your own. And people volunteering to come into services is a very big difference versus people becoming so unwell that they are in crisis and are going into care at sort of in an acute phase. We miss cultural scripts to enhance well-being and cope with stress. And cultural scripts are just like social scripts. Like I want you to think about a birthday party. And a birthday party starts with a social script and maybe sending out an invitation. And the very last part of that social or cultural script is giving children lolly bags as they leave and are collected by their parents. Think about it. There's like an order of things. So all cultural backgrounds have cultural scripts for things. And when someone does something out of order, we notice it. In fact, they might be shunned or shamed for something being out of order, or just like not showing up for a religious celebration with your family. It might be something that's fully accepted because there's flexibility about the cultural scripts, or maybe you're in the bad books because you weren't able to attend things like Christmas or Easter or Eid or whatever it might be. We miss cultural resources in the forms of beliefs or stories or religious verses or belief systems or stories from their background or traditions or things told by their parents or elders. We miss rituals that give people routine every day. So things that people might do, whether it's prayer from, as soon as they get up and out of bed in the morning, or brushing their teeth too, but it could be we're looking for sort of culturally embedded rituals that help people to feel a sense of purpose and meaning in their day, and ultimately routine, which is really protective for mental health. Looking for people like places and people, so we start to understand a sense of belonging and where people fit into our community, and where that if maybe there's deficits in that, and maybe that could be enhanced. So it's again an opportunity for some help seeking or caregiving. And cultural stories, we miss that around stories that embed things like cultural values or aspirational figures that people aspire to be like, particularly in times of adversity or difficulty or unwellness, and digging much deeper for culturally influenced strengths. So I love having a strength-based focus and drawing out culturally influenced strengths, not just personality attributes as strengths, because there's a deeper meaning, a deeper connection for people if we can help people to enhance their ability to activate some of those strengths in their life. Culture matters in mental health. I think it's real. If you do a little bit of research into the development of the DSM, for example, the DSM is very culturally influenced. Most research in our areas of mental health are used on Western white middle-aged men, for example. And so a lot of the treatment modalities do indeed have cultural limitations, and we have to acknowledge that. And so as an example, in the massive, Bible-looking thing that the DSM is, if it's very rare for clinicians to ever make it down to something like page 849, which is where the cultural formulation interview is held, right at the back of the book. So even if we haven't had any exposure and it's slowly cultural formulations have made its way into the DSM, who sees it? Have you ever seen it yourself? Do you know what a cultural formulation interview looks like? Or how to embed cultural factors into things like diagnosis? Lots of questions to ask. Here's one. Is what we know about mental illness and service delivery true and applicable for all people, regardless of their cultural background? The answer is no. The answer is absolutely fundamentally no. And so, but we don't know what to do with that because we've all been taught in a very universal way around how to apply our methodologies to people, not how to modify it and how to really think and hypothesize, is this treatment going to work for this person based on how they experience the world? Something to really start to question what your practices are in your services. Does it get questioned? Do you do things differently? And indeed, if you have, what are they? Because they indeed could be best practice of how to modify things. Culture affects the way people describe symptoms, not just because they speak different languages, but because the experience for symptoms can be very different. One of my first experiences was working with, or early experiences where this jumped out at me, was working with a Somali family. I was working with a woman and we were using the word depression, and the translator very quickly interrupted me and said that there's no word for depression in Somali language, and said that it's rather felt through the stomach as a somatic symptom. And so the stomach issues that the lady was describing was a way of describing something like what we may understand as depression, but who are we to just use that as, well, she was experiencing depression then, because that's what we made out of it. So we have to be very, very careful to understand that the way people describe the symptom, because if you just heard stomach issues, you might head off and start hypothesizing in the direction of anxiety and not depression, as an example. So because that's how we've been trained. How people label illness, like what people use to label different experiences or different psychosomatic experiences that they have, how they experience distress, what behaviors are defined as normative or not, the type of coping strategies people utilize. Stigma associated with expressions of unwellness is very culturally influenced. Help-seeking behaviour is really important to know what they are. I did a little bit of research early on in my career when I was working in Islamic schools, and the number one help-seeking behaviour for Muslim young people is their mother. Their mother finds out about what's going on in their world before anyone else in the world. The expectations that are held by clients and consumers of us helpers. So culture influences what people expect from us. Here are some things that clients, and you may have had clients say this to you, but they may not say it. Okay. Just wondering about all these different things that clients might think, but may not say to you. It depends on who you are. So things like, how do I open up about my family? I don't want to expose them or say anything bad about them behind their back. I get that probably daily, something like that, of I feeling bad about talking about the relationship that they have with their parents, which may well be really dysfunctional, but also feeling bad at the same time, even articulating that in my session and coming to back them up. They're not bad parents, they're not bad parents, because I feel very guilty about even saying that, or prefacing it by saying, I don't want to, I've got some things to say, but I don't want to talk badly about people who are not in the room. I wonder how much experience a therapist or a counsellor or mental health advocate or clinician, whatever your role might be, has with working with people from my cultural or racial group. That is a valid question. Yeah, essentially, how much do they understand about who I am? Or what stereotypes do they hold of me that they might be referencing in their mind as I tell them something that concurs with one of the stereotypes, and experiencing something what's called collective threat. So having to sort of protect an identity or image of the group to which you identify with, because they're in the media right now and you don't want to experience or say out loud that you're experiencing something just like that, because you want to protect the image of the group. Not saying certain things because they don't want therapists to judge their faith based on how they or their family are behaving. Omitting parts of the story that are cultural or religious, because believing that therapists or counsellors or advocates may not understand the intricacies of some of the cultural scripts, and they may not share it unless you ask good questions. If you ask good questions, then they think, oh, okay, you want to know. Translation. How do I translate this word, concept, phrase, distress experience into the language that you're speaking? Not sorry, I know someone's in the background has their phone. If everyone would go on to mute, that'd be awesome. And last one, I'm not going to tell the therapist that I think there's supernatural influences at play, because they might think that my family, faith, or community are crazy. So there's lots of things going on, and these are just some that I thought off the top of my head. If we don't have a great understanding of culture, then clients may not feel heard or understood. We may misdiagnose them. Clinicians overlook amazing client resources such as stories and strengths that I was mentioning before. We clinicians don't understand why clients waited so long to access treatment when people are only coming in at acute phases. A really common thing that I hear from clients is people often say, I waited 12 months. I thought I sat on this for 12 months before I decided to see you. And most of my clients are not in acute phase. So we know that many clients that do show up in acute phase have obviously waited a very long time and have gone into crisis mode. Blind application of evidence-based treatment modalities. And I want you to think about the word evidence-based. Where is the evidence from and who is it on? So how do we know that it's evidence-based for the clients that we work with if they're not the clients that the treatment modalities were tested on to begin with? Low retention in treatment services. So our clients just not coming back or disengaging after only one or a couple of sessions. Poor treatment outcomes and higher reliance on things like medication rather than types of support to address things like trauma, relationship issues, current stresses that are precipitating or influencing the manifestation of mental health issues. We know that we're not doing something right here. And so there's significant mental health disparities, and I'm sure many of you are aware of some of these, and there are so many more, and I've just identified 4. But people with from culturally and linguistically marginalised backgrounds continue to be underrepresented in mental health service access and utilisation figures. People with calm backgrounds typically present late to mental health services and therefore really unwell, more unwell than the mainstream population. Practitioners are also more likely, GP practitioners are also more likely to prescribe medication at the outset to people from culturally and linguistically diverse or marginalised backgrounds than to people from Anglo backgrounds. And this is a really interesting statistic, and I'd like to see it improve significantly, but 50% of clients from minority groups do not return to a counselling session after their first session because they're dissatisfied with the service or they don't believe that there's something that they're getting out of it. And that's even if clients do show up. We've still got a lot of work to do, and I'm hoping that as we start to really understand how to work more effectively with people from all backgrounds and understand that this is about a relationship that we're holding, understanding that we, the clinician, have a lot of power about how that goes. Cultural intelligence I've headed towards as a methodology because it focuses on the relationship and as an outcome, and it focuses on a clinician's skill set that needs to improve the outcome, which is a culturally safe relationship, in my opinion. So I see that cultural intelligence is a conduit to things like achieving cultural safety, particularly in mental health spaces. Cultural intelligence is an evidence-based construct. And it's a measurable individual capability to relate effectively in intercultural interactions and in cultural contexts. Measurable meaning you can undergo a CQ assessment and you can determine your own level of CQ, and that it can be trained. So it can, similar to the concept of EQ or emotional intelligence. So once we identified that, it can be broken down as a way that can be trained. It's very different to IQ, which is largely stable over time. But CQ and EQ have been found that they can be trained. So assessed, where are you now? Get trained, improve it, and assess and evaluate where you are. A level of CQ or cultural intelligence has been found to predict our relational performance in multicultural contexts. And that's what I like about it. I think it puts the emphasis firstly on an onus on the clinician to improve their relationship that they're holding with people, which I feel is foundational for improvements in mental health. Cultural intelligence is a malleable set of capabilities that research suggests can be enhanced by multicultural experiences, bilingualism, CQ training, cultural self-awareness, and travel. However, for those that think I'm very well traveled, I've been around the world, or I've lived in places for a particularly long time, there is interestingly an inverse relationship where the more you are traveled, the less CQ you tend to have. So it's an interesting little dynamic there. Perhaps you just switch off. When we tend to go overseas, maybe for the first time, or to a new country, or to perhaps working with a new community, we're actually very cognitively aware of what's different. And so that ability to go, oh, this is different. Oh, I feel different in this context, and noticing a lot more when you're in the initial phases of community building or traveling is really important to cultural intelligence. But after some time, familiarity, our brains get lazy. And so we switch off that curiosity and we just go, oh, I'm just going to be myself. Like that'll be enough if I just be myself in this context. Or I stop questioning things and saying, what's going on here? How might things be different? So as soon as we stop doing that, we're switching off and going into autopilot mode. So to develop cultural intelligence, it is something that needs this continuous, I guess, metacognition, which we'll talk about as part of CQ, to have that awareness of what am I doing here? Is this working? So this sort of like thinking about your thinking in the context of an intercultural relationship, or how am I being received here? Am I being too direct, too indirect? What type of knowledge would be really useful here for the client? What type of knowledge would be really useful for me to understand the client? I've already said that about the cultural intelligence as a capability, I believe is a conduit to achieving cultural safety. Enhancing the awareness of the cultural elements of the relationship between client and clinician, in my opinion, can prevent clients from being further marginalised in our healthcare services or minoritised or othered, and therefore providing an anti-oppressive space for clients. And that would be a fabulous aim for all of the services that we're offering. The acknowledgement of the role of CQ positions the therapeutic relationship as an intercultural one. The CQ is underpinned by a 4-factor model. And the first factor in the model is called CQ drive. And it's the motivation that we have to relate to people who are culturally different from ourselves and our confidence in culturally different contexts. And so it's really looks at a couple of different factors that underpin CQ drive, our intrinsic motivation, to basically do the right thing, to close the gap, to address injustices, or perhaps a deep curiosity and passion for things that around learning about humanity and how diverse it is. And so it can be, one is intrinsic motivation, the other one is around accountability, so things like extrinsic motivation. So for sometimes it's a what's in it for me? How will this improve? It could just be a what's in it for me? This feels good because I'm able to facilitate and be very fluid and effective in my relationships with people. But it also looks at things like accountability and reward. So companies, for example, if they export something or try to export part of their business overseas, they're highly extrinsically motivated to want that to work and to want their multicultural or intercultural or global business to work. So they're extrinsically motivated. For us, it could just be about KPIs, or it could be about internal types of achievement that need to be set. I would go so far as saying things like attending professional development because we need to fulfill our registration requirements might fall into part of that. The third component of that is self-efficacy, seeing yourself as having the belief in your own ability to be able to do this and to work effectively across cultures is a really important part of CQ Drive. So here are some questions just positing that and just summarising that. And perhaps these are questions that you could take to some of your staff members and teams to look at. Why do we need this? So this is an interesting one, like what motivates mental health clinicians, and why do mental health clinicians need to demonstrate cultural intelligence in their support of clients and consumers in multicultural Australia? It's just a really important question to start thinking, well, why do we need this? And they can be obvious answers, but it's a really important question to ask to actually start punching up motivation to want to change something and to be aware. Extrinsically, what body keeps organisations accountable with regards to the provision of cultural intelligence services? Don't know, you tell me. Do clinicians feel confident in their own cultural competencies to effectively engage with culture in the counselling room? Good question. And if you don't, come to our training. CQ knowledge is the second component, and it's your knowledge of how cultures are similar and different. And this is really interesting because this is basically this little component of CQ is where most diversity or cultural awareness training has sort of surrounded, and not much more. So not so much in the other areas of of the CQ model. So it just focuses on what do we need to know about that group who's different to me. Whilst we do not need, in cultural intelligence, the methodology is such that we know that you don't need to have knowledge about every culture in the world, but it is the ability to start to, depending on your context, to see that as important around who you're working. So if you're thinking about engaging or getting up a mental health awareness project or doing some community engagement or communications with a particular community, it will very much be beneficial if you have some CQ knowledge about who the community is and finding people who are able to inform your strategy with regards to that. Notwithstanding that CQ knowledge is also about your level of cultural self-awareness, and this is very underrated. Even within the original CQ model, this is underrated, but in my experience, this is underestimated how important this is, our own cultural self-awareness, how we operate. And in the training that I'll be talking about towards the end of this seminar, I'll talk a little bit more about things like cultural values and ways to understand how people from different groups are similar and different, not going a little bit beyond what people's customs and celebrations and rituals are in their day. How we use our cultural knowledge and when we use it improves the credibility and trust we have in intercultural communities and in our intercultural relationships. And that's what we want to do. We want to utilize certain levels of knowledge so that we can secure people that they want to come back and access our service because they trust us. This is just interesting images to get you to think about how cultures are similar and different. So the top two images talk around the cultural value dimension of power distance. So on the left-hand side, so it's hierarchical, so it's sort of demonstrating cultural groups that might have high power distance, where there's acceptance that some people have power and other people do not. Whereas on the right-hand side, it's more of an equality type of or an egalitarian focus in society. As an example, Australia is relatively low on the power distance scale, which actually means that they value things like equality and egalitarianism more so than hierarchy and high power distance. And we see that present in family systems. We'll see that present in a relationship dynamic between you and a client, or indeed inform some of their belief systems about why things should be in a particular way. Another one is individualism and collectivism. It's the most studied cultural dimension in the world. It has a lot of ramifications for how we work with people. And insofar as there's research that talks about that communities or countries that are higher in individualism have higher suicide rates, and which, as in the higher separateness that we have in society. So if they're very high, it correlates with things like higher suicide rates as compared to collectivist countries or cultures. That third one, and there are many, but I'm not going through them all today, is uncertainty avoidance. So it's the degree to which cultures like tradition and proceed with caution, so as in they might avoid taking risks or avoid new things and prefer things like stability and what is known as opposed to changing things. So in our two-day course that's coming up in a few weeks' time, we go much more into the cultural values and how they actually come out in the counselling room and in mental health presentations, and very much an understanding of where do you fit on these cultural value dimensions, because that'll influence the relationship you have with your client or the communities you're trying to engage. CQ strategy is the third component of the CQ model, and it's the extent to which you plan, adapt, and review your effectiveness in an intercultural interaction. So before you have that interaction, if possible, during an interaction, and definitely after it. And so some of the things that we might think about strategically that are influenced by culture is our approach to things like mental illness, us holding an etic or emic approach, which is basically sort of a universal approach or going a little bit more culturally relative to what's going on for the person and or the community experiencing the different mental illnesses. The validity of things like psychological assessment within diverse contexts is really important, given there's so much bias, and many of our tools, our very common tools that we use to assess mental health issues, well, actually most psychological tools are inherently culturally biased, and we need to know where and when so that we can factor that in and not make very definitive conclusions if we know that the tool that we used was inherently biased. Recognizing the power dynamic in the room based on your identity and your role, so the role that you hold. And I would go so far as to saying where you put your chair in your room will influence your perception of power. Whether you sit in a chair or whether you offer any chair to sit will influence your power. But it's interesting to note that sometimes you may well need to hold power with clients. Otherwise, your status or credibility might actually diminish with certain clients. As opposed to just operating from your own perhaps low power distance framework. Clinician cultural value awareness, which is really important. Where do you sit on the continuum of things like individualism and collectivism, power distance, and many of the other ones that we will discuss later. Clinician racial identity awareness, I think, is a really important one, understanding who we're working with and how that might influence the dynamic within the room. And whether that needs to be spoken about. And sometimes it does. It absolutely needs to come out as a conversation in the room, so that the client is aware that you're aware, and to sort of bridge any gaps there or have any conversations that need to be had in order to achieve things like trust and cultural safety in the room. Treatment effectiveness within diversity, I've mentioned that before. Some of the ethical considerations that might need some strategic input for you are things like, particularly for treatment decisions, are around awareness of our clients' cultural background and intersectional identity, and finding ways to actually either have conversations through cultural formulation interviews, just getting basic information on cultural questionnaires, or just asking basic questions, which is what our course is designed to teach people around what to ask, that is are culturally safe questions to sort of explore the role of culture in someone's life. Having a commitment to anti-racist and anti-oppressive practices is also a consideration for the type of treatment that you choose, and to ensure that it's bringing out people's best. Even I'd go so far as to say, how were you informed? How did you learn to take notes when you were going through perhaps any of your training, like clinical notes? And I'm wondering that even how we were taught to take clinical notes is culturally influenced. Okay, it's influenced by the institutions that we went to, or by the supervisors that we had, or by the expectations of the organisations that we work with. But how does that advantage or disadvantage certain communities that we work with? So if, for example, we are working with culturally and linguistically marginalised communities, and we just happen to be incredibly, only diagnostically focused or problem focused, I want you to think about then how those notes could be used against our clients. They could be used against our clients because of the social political context. If we think about this, then we might be more open to being fair and balanced about who the person is for us if we ask the right questions when we're spending time with our clients or consumers. So things like their strengths, their connections, their support systems. Their strengths are really like having strength-based notes is really an equitable process for our clients. So that if our notes are ever subpoenaed or used or reviewed, that we're giving a fair and balanced and a full perspective as to who someone is. Being able to identify client culturally influenced strengths and resources and putting those in your notes is really important. Incorporation of psychospiritual approaches to therapy, a massive topic to explore with clients, but also in your how comfortable do you feel doing that or bringing that up as a topic with your clients. Collaboration with ethno-specific services or religious-specific services, bilingual, bicultural practitioners, having secondary consultations with people who are in the know or people who are connected, other clinicians who are from communities that you're working with, and resourcing each other with knowledge about what's happening and what are some of the issues that the broader communities are experiencing that may well be influencing clients. And that will come up significantly in our training, where we talk about the influence of things like Islamophobia, the social, political, global context and how that's affecting Muslim mental health. At the moment, they're really important things to understand and unpack someone's presentation in a mental health context. Understanding the role of family, community or faith leaders, elders in recovery and wellbeing. So bringing in where possible, and not all services have the ability to do this, but thinking about the possibility of how do you bring in other people who have credibility, who do have status to communicate certain messages, or to be there to support people who are going through unwellness. And lastly, CQ action. So it's the extent to which we adopt all of that and then translate that into our behaviour, but more specifically things like our speech acts, so how we speak to clients, our understanding of cultural scripts that might influence the way that we do things, the timing of the things that we do, and understanding and using sort of our cultural knowledge to maybe make some modifications or be flexible in the way that we offer things or the way that we communicate information or offer clinical services. Now, just a little bit, just before I'll open up to any questions that anyone would like to ask, is we have a course, CMW has a course coming up, and it's a level 1, level 2, but the one that's coming up is level 1. It's Cultural Intelligence in Mental Health Care. I am facilitating it, and it's running through 6 modules across 2 days where we look at cultural intelligence in mental health in a little bit more detail than we've done today. And then we delve a little bit more into culturally intelligent care with Muslim clients and communities. And then I have an extensive run through of cultural values as they affect you, the client, and the relationship that you're holding with clients. We look at social linguistics, so it's how culture is embedded into language and cross-cultural communication styles, and how that actually influences things like treatment outcomes and the type of treatment that we offer. And we'll have a very hands-on go at developing a cultural formulation for clinicians. So if you are interested, there are still spots available, and please visit the Centre for Muslim Wellbeing's website, which is cmw.org.au. It's on the screen, and please register, or indeed if you know people who are interested, and please share that information amongst your colleagues. It will be followed in a few months' time with level 2, which is a little bit more of an in-depth look at some of the things that build on the practical applicability of cultural intelligence in mental health care.